Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, thank you for joining us for the 2025 Clinical Viewpoint on Uncontrolled Gout. This is a lecture library series, and the lecture is titled Precision in Practice, Elevating Care for Uncontrolled Gout. My name is Dr. Robert Terkeltaub, and I'm a professor emeritus, Department of Medicine, Division of Rheumatology, Autoimmunity, and Inflammation at the University of California, San Diego. These are my disclosures. And here's our agenda for today. We'll talk about how we see the objectives of this learning activity, how we understand gout pathophysiology, and a major focus is on the disconnects, diagnosis, and where we are now, and missed opportunities and how we're filling those gaps. And the next section will talk about pipeline efforts to fill the gaps in the emerging therapeutic landscape. And then we'll conclude with the takeaway messages. The learning objectives are primarily upon completion of this material that the participant is able to describe pathophysiology mechanisms driving systemic inflammation in gout, including the IL-1 beta release and activation and NLRP3 inflammasome involvement, clinical implications of that beyond gouty arthritis, and then identifying when and how to escalate urate lowering therapy in accordance with current gout treatment guidelines, including the treat to target guidelines of the rheumatology societies, including the American College of Rheumatology, and the treat to dissolve strategies in rheumatology that are used for more severe disease, including severe tophaceous gout. And then the last objective is to explain mechanisms, evidence, and clinical roles that we see for emerging therapies for refractory, uncontrolled gout, including novel immune modulating biologic combinations, URAT1 inhibitors. And those are today's objectives. And now we'll talk about the first one, which will be understanding gout pathophysiology. So basically, what defines gout? Chronic systemic accumulation of urate with crystal deposition of monosodium urate in joints and various soft tissues. The stereotypic acute gout flare, sudden onset, often in the middle of the night. Severe joint pain characteristically with redness, warmth, swelling, tenderness, impaired function of the involved joint or joints. And then gout being a chronic disease punctuated by the acute flares, but a chronic inflammatory disease with recurrent flares, persisting inflammation, including systemic inflammation. Tophi will describe the pathophysiology of tophi and the tophi associated with bone erosions and joint damage. One could quibble about some other things that aren't in the classification of gout, such as kidney stones, which are so frequent in gout patients, and the rare complication of chronic interstitial renal medullary tophaceous disease. But for classification purposes, these are the criteria really that define gout, and they're mainly clinical criteria. So when we unmask the unmet needs in gout, we're talking about a widespread and most commonly undertreated condition in a very well-defined disease. So how common is common? We're talking about 5% of USA adults is our best estimates most recently, and the numbers continue to go up. And gout is the most common form of inflammatory arthritis. This is a historically well-described disease dating back centuries and millennia, really, with well-defined pathogenesis, as we've discussed in the learning objectives and the characterization of what defines gout, and then a persistent clinical paradox despite these outstanding consensus-based guidelines from the American College of Rheumatology and from EULAR in particular. Gout remains poorly managed in the United States and often in other countries, many other countries. And so the ongoing challenges always include the patient's perspectives and the stigma of having gout and with misconceptions about the disease, the episodic nature of care rather than treating gout as a chronic disease with acute flares, and the underutilization and underdosing of urate lowering therapy, which is really a systematic problem, not just a problem of clinical practice. So, what is uncontrolled or chronic refractory gout? There's no consensus definition yet, but it's being worked on by various societies, including the GCAN Gout and Crystal Arthropathy Network. For clinical trials, the typical fundamental criteria are shown on the slide. Serum urate greater than 6, or at least 6 or more, and then ongoing clinical manifestations, joint pain, tophi, flares, typically, despite appropriate oral urate lowering therapy. And what's appropriate is subject to some discordance between primary care and between the rheumatology subspecialists. The more precise factors used to categorize what's uncontrolled or chronic refractory gout include the following: excessively frequent flares. That means at least 2 gout flares per year, according to the American College of Rheumatology. And the EULAR views at least 1 flare as excessively frequent, but the American College of Rheumatology definition is a little bit more lenient. Very severe gout flares, somebody that has to go to the emergency department or have to be hospitalized. Polyarticular gout flares, which are more common in older patients and can be a severe systematic illness. Baseline hyperuricemia, not just the flare activity, but the baseline hyperuricemia. If it's over 8, that's pretty bad in terms of the longer term prognosis over 10 years from a recent study published in JAMA that we'll talk about. And if it's over 9 and over 10, it's even worse in terms of the prognosis for active arthritis and also for gout flares that require hospitalization. Gout disease activity that's linked to worsening comorbidity, particular cardiovascular events, and we'll talk about that. Palpable tophi, which are something that you see with a high urate burden in the body and high level of monosodium urate crystal deposition, with the associated chronic inflammatory tissue reaction. As we'll talk about, tophi are not just a rock of urate crystals. In fact, they're not really a rock of solid urate crystals. They're a complex chronic inflammatory structure. And then impaired joint function. And you can see these slides, the gradation from the top to the bottom of what an acute flare looks like, and then what chronic, aggressive, destructive, erosive, tophaceous gout looks like with impaired joint function, bone erosion, soft tissue damage, ulcerating tophi. So, these are the factors at play that come into defining what chronic refractory gout is, what uncontrolled gout is. So, how do we therapeutically correct urate homeostasis? We have to balance urate production and urate elimination. And normally, about 2/3 of urate is excreted by the kidneys, but a third is excreted via GI tract disposition. That includes excretion in stool, but also includes urate and purine degradation and utilization by the gut microbiome, a very complex and evolving area that perhaps in 5 or 10 years may be more prevalent in our pipeline of therapeutics, but right now has just been discovered to be a quite important contributor to urate balance. And disruption of any of these mechanisms will can promote hyperuricemia, but primarily, and this is the vast majority of patients with gout, you're dealing with patients that have impaired renal urate excretion, and some have impaired gut urate elimination, and a few will have urate overproduction, and some of that, what we thought was urate overproduction is really actually decreased GI tract elimination and overload of urate on the kidneys. So our definition of uric acid overproduction has changed, but some uncommon genetic conditions will cause uric acid overproduction, and then some secondary medical conditions will cause that as well, like myeloproliferative disorders and psoriasis as prime examples. And the mechanisms of impaired excretion, again, decreased renal urate elimination is the boss factor. It's involved in about 90% of hyperuricemia in gout patients. And the key transporters have been identified in excellent work over the last couple of decades. They're listed here. And the ABCG2 transporter is the king in terms of bringing urate into the gut to be degraded and excreted. And mutations of these transporters, these are really common variants. They're not rare mutations at all. They're extremely common, and especially in certain populations, including East and South Asian populations. They can cause persistence of hyperuricemia. And then there's things that happen over life. It's not just your genetics, but there's things that happen over people's lifetimes that they acquire that can lead to decreased renal urate excretion. Hypertension, chronic kidney disease, obesity, insulin resistance, metabolic syndrome, type 2 diabetes is what we're referring to. And thiazide and loop diuretics and other drugs, cyclosporin probably being the worst of all of those other drugs. So there's lots of things that upset balance. And we have to think about that when we think about the individual patient and how to treat that individual patient. So the beauty of what we have discovered in the last 10, 15 years is that gout is a disease, a rheumatic disease that's subject to disease modification. And we know what disease modification is in rheumatoid arthritis, in spondyloarthropathy, where we have decreased symptoms, decreased structural modifications, such as in rheumatoid arthritis. We were very concerned about joint erosion, bone erosion, and cartilage damage, and that we correct the underlying pathophysiology of the disease here, urate homeostasis. So the beauty of this is we know that we can have achieved very effective disease modification. And this is this knowledge has arisen by large controlled studies. And when you titrate allopurinol and febuxostat in large randomized controlled trials where there's rigorous protocols and people that are non-adherent are dropped out, you can achieve a target serum urate of less than 6 in 80 to 90% of patients in the general population that you're recruiting from. And that's in prospective, beautifully controlled trials. Now, the time frame for benefit in terms of treating urate to this bare minimum target of less than 6 is 1 to 2 years for particularly important outcomes that we look at clinically, and that's flares, and by advanced imaging, and that includes the urate burden that we assess by dual energy CT, and urate deposition, urate crystal deposition that we can assess by ultrasound, although it's less quantitative than the dual energy CT. And it takes 1 to 2 years for the flare burden on average in a population of patients in the trial to decrease. And it takes 1 to 2 years for the protective effects on bone erosion and joint damage to become manifest by advanced imaging. And that includes synovitis imaged by MRI. And if you sustain that urate lowering therapy to below the target of less than 6, you improve the urate crystal burden, the crystal deposits and tophi, and that's the iceberg that you see on the upper left, and then the dual energy CT that you see with the urate crystal deposits in green. They will decrease with target achievement. And then symptomatic flares that are characterized by the forest fire that we see in the left graphic and then chronic gouty inflammation, they will improve. And the structural effects include healing of bone erosions, decrease of synovitis, and other forms of joint damage and healthier joint function. So that's the beauty of disease modification by treating urate to a target level and keeping patients at a target level. The duration of clinical remission in gout, there's been various definitions of this. The 2025 GCAN definition is really the simplest. Absence of gout flares in the last 12 months and absence of subcutaneous palpable tophi and a serum urate below 6. That's remission. And in the average patient, you get pretty high remission rates by 1 to 2 years. In the more severe patients that we'll talk about that get on pegloticase, somewhere between half to three-quarters of those patients get to remission by 1 year. So it's a pretty rosy picture if you treat to target. And successful treatment to target has another tangible benefit, and that is a benefit on a major comorbidity, which is mortality. Gout patients have elevated mortality, and elevated cardiovascular mortality is included in that. And if you get people to a serum urate target of less than 6, the survival function and the cardiovascular deaths both decline. So that's really important to remember. And when you're trying to persuade patients to take urate lowering therapy to target, it's something that you can bring up. So the fine details on how reaching urate target improves survival. Basically, besides the mortality risk, it's all-cause mortality. You have greater benefit the lower you go with the serum urate levels. So if you get below 5 milligrams per deciliter, a level where on imaging studies you actually see the urate crystals dissolve when you do dual energy CT studies. And you do this particularly in patients with comorbid conditions like type 2 diabetes and hypertension, CKD. The lower the serum urate, the lower the mortality, the greater the benefit of urate lowering therapy. And then the persistence of hyperuricemia linked to higher mortality, underscoring the long-term nature of the benefit of urate control. So, what are we talking about in terms of decreasing flare activity? And well, to understand that, we should talk about what causes the flare. And it's more complex than what's shown on this slide. But work that started about 20 years ago has defined, I think, to everybody's the broad knowledge of everyone in the medical community, that the NLRP3 inflammasome, which you see bottom center of the graphic on the right, is primed by different inflammatory signals. And if at the same time the urate crystals, the monosodium urate crystals, are ingested by mononuclear phagocytes, as you can see in the top middle of the graphic, you activate the NLRP3 inflammasome. And that leads to the secretion of IL-1 beta. And IL-1 beta is the boss cytokine in driving the inflammation cascade in gout. And a lot of this has to do with the forms of cell death that you see and the massive recruitment of neutrophils into the joint tissues and the bursa when you get a flare. And the neutrophil recruitment is a huge amplifier and driver of the flare activity. So this is the basics of how you get local inflammation, and there's spillover of the local inflammation to systemic inflammation that affects the comorbidities, particular cardiovascular disease. So this is therefore a pretty important slide. So another important slide is that the pathophysiology of tophi, only up to a third of the tophus area is comprised of urate crystal deposits. On the left panel, you can see dual energy CT, and by the shadowing in panel B and then panel C, you can see that the urate crystals are only up to a third of the tophus area. There's large open spaces in the tophi containing fibrosis. You can see here in the center panel, the bottom center panel, the large intervening areas of fibrosis. And then on the upper central panel, the chronic synovitis. And then the right panel, some granulomatous changes that you see in the tophus with B cells and T cells around the core of crystals, as well as macrophages in that area. So you have chronic fibrosis, chronic inflammation, and urate crystal deposition. And the fibrosis and the chronic inflammation make it very hard to get rid of these tophi. That's why it takes so much time, because in fact, also the urate crystal deposits in tophi dissolve on very effective urate lowering therapy well before the chronic inflammatory reaction to the crystals subsides. And when those crystals are breaking up, the inflammatory reaction can increase. So that makes it even more complex. So this explains what you see in the clinic that we'll talk about when we talk about drugs such as pegloticase and SEL-212. So systemic inflammation in gout also makes it more difficult to take care of patients. You have a tangled web often of gout and hyperuricemia and comorbidities that are also driven by chronic inflammation. And it makes it difficult, especially when the patient's on 10, 15, or 20 other medications, to find a strategy that controls everything and that's free of drug interactions. And sometimes there's an economy of scale because you can use some of the same medications that you use for the comorbidity to help with the control of gout. And that's exemplified by the SGLT2 inhibitors that we use for diabetes, heart failure, and CKD, for example. And then you have to make a lot of therapeutic moves carefully in patients who have these comorbidities, and often patients have not just one comorbidity or two, they might have 5, 6, or 7. So this is the reality of taking care of patients. There's a lot of polypharmacy in the gout patients and a lot of polycomorbidity in the gout patients. And the clinical relevance of this is that gout is a contributor to the systemic inflammation, that the inflammation of a gout flare is reflected in systemic inflammation that doesn't subside for a few months. And that's why gout is a predictor of systemic morbidity and mortality. And it underlines the importance of proactive disease management and identifying systemic inflammatory diseases. Often it's the rheumatologist that will order a liver ultrasound, for example, that identifies the MASH in a patient. And we don't have all the studies yet, but it appears that the better that you manage gout, that some of the comorbidities come along also better in terms of their management. And so recognizing the comorbidities and managing them well improves all patient outcomes and quality of life. So now let's talk about recognizing the disconnect and how diagnosis and classification of gout have advanced significantly since 2015, and what our missed opportunities are, and where we're filling in the gaps in missed opportunities in the overall management of gout. So this slide reframes how gout diagnosis looks since the 2015 ACR-EULAR classification criteria, which was historic in a way, just by getting ACR and EULAR together to do this, recognizing the severity of the problems and the unmet needs, but also adding the features of advanced imaging to plain X-ray to help in the classification of the disease. And the left panel shows some graphics. The upper left panels labeled A show the classical double contour sign of gout with the hyperechoic signal being on top of the articular cartilage surface and also on the top of the subchondral bone. And then the middle panels show the utility of dual energy CT with the positive signals, including the Achilles tendon on the right, and in joints of small joints of the foot on the left. The utility of dual energy CT in the specificity of gout classification, and when certain cases are in doubt, and then helping to assess joint damage. And then the bottom panel, plain X-ray, the classic erosions of gout with well-defined margins, big rat bites, overhanging edges, and how important that is still in classifying gout. And so basically, these advanced imaging features are worth a lot when you score gout. And the ultrasound and dual energy CT, for example, the scoring of gout in these criteria equals finding a palpable tophus. So that shows you the value of these advanced imaging features. And in this classification criteria, a score of 8 or more classified as gout, and the classic symptoms, clinical time course, as well as lab features, serum urate, either negative with negative scoring if the serum urate is low, or progressively positive scoring if the serum urate is elevated, adding up to really very accurate classification criteria for gout. And this really helps in clinical trials and helps in the clinic as well. It sometimes helps to convince not only the doctors but the patients that we have the right diagnosis and it's time to initiate therapy. So despite all of this and really recognizing the disease even better than we ever have, there's still a lot of missed opportunities for optimal gout care. And one can think about this in many different ways, but I think a grave problem is the healthcare disparities that we see that includes the really poor access to care and quality of care in African American patients and Hispanic and patients of East Asian ancestry in the United States. And this is important in part because gout is more prevalent in the United States in Black and East Asian descent patients. And there's a shortfall in evidence-based care for these patients, including allopurinol use and dosing, and also in patient education, poor adherence in Black patients, less access to primary care in patients in these minority groups, and disproportionate gout emergency department and hospital visits with higher medical costs for these groups. And you can see on the right panels the risk ratios for emergency department visits, and on the bottom right panel, the rate ratios of hospitalizations being markedly disproportionate in those who are Black as well as Hispanic in the United States. And the missed opportunities are we probably do not get specialists such as rheumatologists and nephrologists to a certain degree involved enough in gout management. Primary care manages by default really the most gout cases, but a lot of these patients fall into the cracks and their gout flares are handled in urgent care or handled by themselves with over-the-counter medications or not handled at all and not reported at all. But basically, rheumatology takes care of a very small fraction of gout patients, and rheumatology gets the most involved when there's uncontrolled and tophaceous uncontrolled disease. And the other issue that we have in terms of missed opportunities is that there's key differences in the guidelines for long-term gout management between rheumatology, represented here by the ACR in the middle columns, and the American College of Physicians representing primary care. And the guidelines from the American College of Rheumatology are treat to target, treat to serum urate target, being less than 6 at a bare minimum, less than 5 if patients have palpable tophi or very severe gout with some of those criteria for uncontrolled gout that we discussed, including very severe flares, and advocates for urate lowering therapy, with allopurinol being the first line drug still by the 2020 guidelines. And prevention of gout flares during urate lowering strongly advocated by use of colchicine for 3 to 6 months. Really, in my opinion, it could be longer, especially a period of months after you get the serum urate to target. We would get better results with colchicine according to recent clinical trial work. And then treating flares when they come up, very similar recommendations for using NSAIDs, colchicine, or prednisone from primary care and the American College of Rheumatology. But with the advocacy and the guidelines for urate lowering therapy, much more ambiguous, really, with the American College of Physicians. There's no clear guidance for using urate lowering therapy. There's no guidance on treat to target, and these guidelines are supposed to be renewed every 5 years or so. They tend to be renewed more like every 7 or 8 years. But the American College of Physician guidelines are overdue now to be reviewed, and we're hopeful that basically there'll be a change in those guidelines. But this, as well as patient hesitancy and other issues, really leads to a lot of missed opportunities for better treatment of gout. So primary care has the treat to flare approach, which is somewhat reactive, as we see in the left panel. And rheumatology has a treat to target proactive strategy, and the guidelines of with their discordance and the consequences of that are summarized in the right panel. But clearly, gout is undertreated by the population of healthcare providers who treat the vast majority. We're talking about over 90% of patients with gout, and that contributes to outcomes that need improvement. And that's not something that's in dispute in rheumatology. The patient's perspective is ultra important. And there's lots of issues that have been, come to the surface in excellent clinical research. And gout still is felt by some people to be a self-inflicted disease from diet and alcohol, whereas the role of genetics and comorbidities seems to be discarded, seems to be taken as misinformation. And the common media trivializes often and the severity and consequences of gout, which undermines the urgency for care. And there's some gout shaming going on as well. And lots of misinformation, inadequate communication, and a lack of shared decision making contribute to the issues. And there's mistrust of the healthcare providers by the patients when it comes to gout. And the patients question the rationale for urate lowering therapy and often feel that they're over medicated, especially with allopurinol, where they're getting hundreds of milligrams of allopurinol, and now you want to give them more hundreds of milligrams of allopurinol. So these are all huge issues that would take an hour actually just to discuss separately. So the patient-focused care and communication, well, how can we improve that? Well, doctors, MDs, have issues with the amount of time available for the encounters. So bringing in allied health professionals into the equation for management has been shown in multiple studies to improve gout outcomes. And instead of in primary care in the real world, instead of getting 20 to 25% of people to a serum urate target in primary care, in clinics where there's protocols used and allied health professionals such as nurses and pharmacists and physician assistants are brought in, you can get 70% or more of patients to target and have improved outcomes in those types of protocolized clinic structures. And the really launching pad for this was a study from Nottingham where nurses were brought into the equation, and there was a comparison to standard primary care. And you can see the inclusion criteria. Lots of people studied, and the key outcomes at 2 years. Nurse led 95% of people to serum urate target. The primary care led 30%. That's a pretty good number. Usually it's well below that, as we've mentioned. And so all of the outcomes, including flare frequency, tophus dissolution, between 1 to 2 years, all of these better with the nurse-led care and getting people to target following the Rheumatology Society guidelines. Now, we need a reality check because in the Western world, things are not so good in terms of the quality of care. Allopurinol is dirt cheap. It's so inexpensive, under $100 a year. And the also FDA mandate that allopurinol should be the first line of urate lowering therapy, not febuxostat, that mandate from 2019. That has really pinned the first line of therapy to be allopurinol, and its market share is about 95% in the USA for the first line urate lowering drug and the one that's used to treat gout patients. And so basically, the maximum dose in primary care, typically 300 milligrams a day. The mean dose, about 200 to 220 milligrams a day. And that just doesn't get enough people to target. You need to get to 400 to 500 milligrams a day of allopurinol to get people to a serum urate of less than 6. And starting low with allopurinol and going upward slowly has some benefits. This is the typical and FDA mandated and guideline approved regimen. Allopurinol, start low, go slow. It limits the development of allopurinol hypersensitivity syndrome, which is somewhat dose dependent. And in randomized clinical trials, you get 80 to 90% of people on allopurinol like this to target with good outcomes over time. The drawbacks are the prolonged time to achieve urate lowering therapy target, the time to target, because it takes a lot of encounters with a lot of up titrations. The up titrations are by no more than 100 milligrams a day. It takes a lot of time to get to the urate target, and patients think about that. And then when patients have a gout flare, 1 out of every 2 getting a gout flare on allopurinol stop the drug, and gout flares will go up when you start allopurinol or febuxostat or any treat to target urate lowering therapy strategy. The gout flare burden is quite high in the first year of urate lowering therapy, so a lot of people quit. And then prolonged colchicine flare prophylaxis is probably needed in way more people than what it's used in. And then some patients are genetically resistant to allopurinol as well, particularly some of the East and South Asian population patients. So this is the reality. So we have also to prevent allopurinol hypersensitivity syndrome better. It's considered to be ultra rare, but it's uncommon, but it's not ultra rare. And up to 5 cases per 1,000 new users globally, depending on the population you study it in. For example, in Canada, there's almost 1 allopurinol hypersensitivity syndrome hospital admission per 1,000 allopurinol initiators. I guess it's rare unless it happens to your patient. And then allopurinol hypersensitivity syndrome, it develops in weeks to a few months. Sudden onset, which often there's no intervening visit to the care provider. An 11-fold relative risk increase with CKD and heart disease. And the allopurinol metabolite oxypurinol is eliminated by the kidneys, so that explains some of the CKD risk. And then a 23-fold higher risk for older Asian females with heart disease compared to non-Asian young men. So it's really not ultra rare. And so the biggest risk factor that we know for allopurinol hypersensitivity syndrome is having HLA-B5801. That has an allele frequency in white patients of 1% approximately, whereas in Southeast Asian populations, 8 to 20%, and in African American populations, about 4 to 7%. Positive for HLA-B5801. And the major allopurinol metabolite oxypurinol is a very small drug, and it squeezes into that binding pocket of HLA class 1 molecules, especially HLA-B5801. And it has a very unusual form of activating the immune system. It directly activates the immune system by this squeezing into the binding pocket for antigen for peptides of HLA-B5801. You get direct activation of oligoclonal drug-specific CD8 positive T cells, bypassing the need for cellular antigen processing and bypassing the need for dendritic cells. And it's not limited to specific T cell receptor repertoires. And so basically, there's other factors besides HLA-B5801. Not everybody with HLA-B5801 gets allopurinol hypersensitivity syndrome, but it's hard to predict because there's so many other factors involved. So you should never give allopurinol to anybody who shows up as HLA-B5801. That's about a $200 lab test, the HLA-B5801. And from the bench to the bedside, you see the severe systemic immune-mediated illness with a 25% mortality rate, allopurinol hypersensitivity syndrome. You see the toxic epidermal necrolysis on the left, and Stevens-Johnson syndrome that can lead to blindness and other horrible complications on the right. And those two go together. Fever, eosinophilia, drug reaction with eosinophilia and systemic symptoms, Stevens-Johnson syndrome, toxic epidermal necrolysis, other rashes, vasculitis, major organ damage, co-infection. The patients often wind up in the burn unit. If they survive, they survive. I mean, the 25% mortality rate is substantial. If they survive, they're often in the hospital for 2, 3, or 4 months. So this is a horrible medical problem. Because of the risk of this, we have to titrate allopurinol so slowly, and so it creates the problem of allopurinol undertreatment and delayed time to target. Now, from a miss to a new opportunity, it turns out that marked JAK inhibition, JAK inhib drugs are like the jack of all trades, gives you a striking therapeutic response in allopurinol hypersensitivity syndrome in a new small case series. This is mediated by the type 1 and type 2 interferon signature that's seen in the immune cell and keratinocyte compartments. And you can see in the pictures the incredibly rapid, these are both patients who got allopurinol, one East Asian patient on the left here, incredibly rapid response to JAK inhibition. So a disease with a 25% mortality rate is now potentially going to be treatable with JAK inhibition with good success. Many other opportunities to improve gout outcomes with current therapies are there. If we use the highest tier of baseline serum urate, greater than 8, to assist in deciding to start urate-lowering therapy, that would be an improvement. Earlier switching to second-line cheap generic febuxostat. Febuxostat used to be $5 to $6 a pill, even for generic febuxostat. Now, febuxostat generic is under $100 per year, same as allopurinol. We anticipate the next American College of Physicians guidelines on recommending more treat-to-target urate-lowering therapy. I think it would be overly optimistic to think that they'll recommend that everybody be treated with treat-to-target, but hopefully they'll recommend more treat-to-target urate-lowering therapy and recommend urate-lowering therapy, which is something that wasn't done before. And then more use of allied health professionals and gout protocol-driven clinics to get people to target with urate-lowering therapy. And we want to selectively align the gout inflammation treatment to the comorbidities. And that includes use of more of the colchicine flare prophylaxis. And I'll show you some of the reasons for that in the next slide. Colchicine is now FDA approved for secondary cardiovascular event prophylaxis, that means on top of aspirin and statins. Not all the results are convincing, but it got FDA approval for specifically for decreasing major adverse cardiovascular events. SGLT2 inhibitors that are approved and very popular, they're uricosuric. They limit incident gout. This is a big development for the patients that have diabetes, CKD, and heart failure. And then IV pegloticase efficacy for chronic gout markedly improved by immunosuppressive therapy. And then new approved gout flare management options, canakinumab, is now approved by the FDA, IL-1 beta specific antibody to treat acute gout flare. Its uptake has been slow. It's an expensive drug. And then using the target serum urate to inform decision making. And you can see that, customizing the target serum urate is something to really consider when you're managing specific patients with gout. And the important thing is that if your urate stays above 6 and you use dual energy CT to image, you'll see new crystal deposits. Whereas if you can get the serum urate below 5, you'll see crystal dissolution by dual energy CT. And if you get the serum urate below 2, you can markedly accelerate the debulking of the tissue crystal deposits and accelerate the time to remission. So let's talk about missed opportunities in using colchicine flare prophylaxis. We're talking about control of systemic inflammation of gout, and that systemic inflammation is not benign. And the examples are that if a patient has had a recent gout flare, meaning within 60 days, there's a markedly increased risk of myocardial infarction and stroke, and an even higher risk of gout flare linkage to fatal myocardial infarction and stroke. And then just recent diagnosis of gout within the last 30 days, or recent urate lowering therapy initiation linked to increased risk of myocardial infarction and stroke. So colchicine now FDA approved for secondary cardioprotection and used at 0.5 milligrams per day in coronary artery disease trials in the first 3 panels from left to right. And you can see the freedom from primary outcome, impressive. That's why it was FDA approved. And then the right panel is a cumulative incidence of the primary endpoint comparing colchicine and initiation of urate-lowering therapy versus urate-lowering therapy alone for major adverse cardiovascular events in gout patients starting urate-lowering therapy. Impressive results for colchicine flare prophylaxis. So a missed opportunity now can be closed by using colchicine prophylaxis more for people with gout, especially those starting urate-lowering therapy and those with recent diagnosis of gout. We're talking about people, especially with risk factors and past primary history of such cardiovascular events. Another change of missed to new opportunities, the ability to use a biologic urate-lowering therapy, specifically recombinant pegylated uricase with immune suppression or immune modulation. Uricase is a foreign protein to human beings. We lost it in evolution, as you can see in the bottom right panel. And uricase degrades uric acid to allantoin, which is much more soluble. And basically, that can be a beautiful and wonderful thing when uricase is placed in the circulation. It degrades all the urate that gets into the circulation 24/7, 365 days of the year, if that's how long you continue that. And the uricase molecule is a barrel of 4 monomers. You can see in the upper left panels, and it's heavily pegylated here by pegloticase in this particular graphic to prolong its circulating half-life and to reduce the immunogenicity. And pegloticase, when it's used appropriately to debulk urate crystal deposits, can be transformative. And within a matter of months, and here, and you can see in these pictures by week 26, the amount of change in this patient's gout anatomy is remarkable. And this is giving 8 milligrams of pegloticase IV every 2 weeks, rapid tophus resolution, great functional and quality of life improvement, and by 3 months or so, decreased flares typically in these patients. And the issue was that this transformative response with pegloticase alone was only seen in about 40 to 45% of patients at 6 months because of treatment emergent antibodies that changed the pharmacokinetics of the drug. These antibodies were primarily directed to the polyethylene glycol, to the PEG that was covering the uricase. But like what you see is remarkable. The resolution of uncontrolled tophaceous gout pathology by pegloticase with healing of erosions and marked dissolution of the crystal deposits on dual energy CT, and also clinically you see how these massive tophi just disappear. So this has been a generational change in how we treat gout. So the limitations, despite the pegylation, clearly the drug remains highly antigenic. It can promote early severe gout flares. I call them jumbo flares, often requiring concomitant protracted prednisone therapy. And you don't give it to patients with G6PD deficiency because of methemoglobinemia and hemolysis. And then the cumbersome regimen every 2 weeks, IV, now being shortened. The infusion time is less now. That's also more feasible with the addition of immune suppression, which we'll talk about in a moment. And a pivotal phase 4 trial program has produced some really cool results that if you can give pegloticase every 4 weeks with methotrexate every week in the first couple of dozen patients that they tried. So there's an ongoing trial that we're going to see conclusions from down the road that's going to be pivotal for FDA approval, giving more pegloticase than 8 milligrams and giving it monthly with weekly methotrexate is under study. And that would certainly be an improvement in the pegloticase regimen. And then the improvement of over baseline efficacy of pegloticase and getting people through a course of therapy is what we're talking about here by adding immunosuppression. The mirror randomized controlled trial, about 70% plus of patients getting through the course of therapy at 6 months. That declines to about 60% at 12 months, but pretty darn good. And then recipe, fewer patients, but like over 70% getting durable response, and these patients being able to stop the mycophenolate in this particular trial. And then azathioprine, not something that I've enjoyed using, and you really need high doses of azathioprine to work. Leflunomide is something else, and some other drugs that are used for organ transplants that being studied as well to get the pegloticase responder rates higher. But this is a tremendous increase in the ability to successfully give a course of pegloticase and get it out to a year or so when you can get 50 to 75% of people to remission. And these are people with very severe gout. So a tremendous advance in clinical care. Another advance is the decreased risk for incident gout with those people using SGLT2 inhibitors, which were discovered to be uricose-uric. And basically to have a lot of interactive effects that are beneficial, including on urate transporters, as you can see in the graphic. And when you weigh the benefits and risks of SGLT2 inhibitor therapy in gout, you wouldn't be using SGLT2 inhibition in somebody without a primary indication for SGLT2 inhibition. But when you use it in type 2 diabetics, you can lower the serum urate by about 1 milligram per deciliter. And in chronic kidney disease and heart failure, closer to 2 milligrams per deciliter is the expectation there. And basically, even if you have a baseline first-line urate-lowering therapy drug, you can get the urate down. It's the anti-inflammatory effects that are the icing on the cake. And the ability of SGLT2 inhibitors to inhibit the NLRP3 inflammasome and IL-1 beta release. There's clearly a decreased incidence of new gout, fewer flares, less mortality, and this is a really interesting addition to the therapy arms that we have available now to treat gout patients with comorbidities. So the last section before our conclusions are going to be the emerging therapy pipeline for refractory gout. Really a new era in our pursuit of optimizing gout care. There are very highly selective oral URAT1 inhibitors, URAT1 being a major reabsorber of urate by the renal proximal tubule epithelial cells. And Dotinurad and AR882 are the prime examples. These are highly selective, very potent uricosurics, derivatives of benzbromarone, which is a drug that's been used for years abroad, but has some pretty significant side effect um, profile issues that will make it impossible really for that drug to be approved in America. But these are derivatives of benzbromarone that are detoxifying benzbromarone in theory. And you can get in phase 3 clinical trials over 70, 80% of people to the serum urate target of less than 6. And what the beauty is that many of these people get to less than 5 and even less than 4 milligrams per deciliter. So they require minimal titration, unlike allopurinol. And so a much simpler urate lowering oral drug regimen is potentially on the horizon here in the United States. Dotinurad is already approved in Japan, China, Thailand, and the Philippines, where there's lots of difficult gout to manage. And then SCL-212, a nano-encapsulated combination therapy of a nanoparticle with rapamycin sirolimus in it to induce immune tolerance, and a pegylated uricase called pegadricase to degrade serum urate in the circulation. And it's designed to be immunomodulatory, not so immunosuppressive, unlike methotrexate, mycophenolate, and leflunomide and azathioprine as used for pegloticase. And we'll talk about the data there. And then NLRP3 inflammasome inhibitors in phase 2 studies. Progress has been slower there, but there's two molecules that so far that have had more advanced study into phase 2, and a third that's emerging that's not mentioned here. And basically they target IL-1 beta driven inflammation and aim to improve on the options that we have available to treat and prevent gout flares. So let's look at AR882. And this is used as a monotherapy at 75 milligrams a day and has been studied with compared to allopurinol and in combination with allopurinol. And the striking thing is you can see in the purple triangles how low the serum urate goes with monotherapy here at 75 milligrams a day, and how well sustained the effect is. At 12 months, it's a mean serum urate of 3.9, which is a really potent effect. And the mean shrinkage from baseline in urate crystal volume using dual energy CT, very impressive with AR 882 at 75 milligrams a day. Very impressive at 6 and 12 months compared to the lower dose with allopurinol. And really, you seem to need the higher dose of AR882 with allopurinol in this graphic here with these bar graphs shown on the bottom. And this is just a representative dual energy CT. This would be like the average patient with gout, but marked resolution of these urate crystal deposits at month 6 and month 12 with an oral monotherapy uricosuric. Really potentially exciting agents here. SCL-212, basically nanotechnology with this ImmTOR particle, a nanoparticle with the sirolimus in it, and then the pegadricase. And the idea here is that you are inducing regulatory T cells, and you really do get fewer anti-drug and anti-PEG antibodies in this way, and without the immunosuppression of the other agents, methotrexate and mycophenolate and azathioprine that I've mentioned. And compared to pegloticase alone, this gives fairly comparable numbers with significant responses What's interesting is that the percent of patients positive or negative for treatment emergent antibodies that affect the drug is pretty low. And there's no infusion reactions that were described in their drug program in phase 3. The antibodies are somewhat different than the ones we see with pegloticase. Here you're seeing more anti-uricase antibodies, and then more so than the anti-PEG and anti-drug antibodies. So interesting option, which at baseline is fairly comparable to pegloticase and is awaiting further clinical development as it goes through its regulatory pathway. It's not approved at this point in time. And here we see the percentage of patients responding to treatment and people with tophi at baseline, pretty much dead on the numbers that you would see with pegloticase. So what do we conclude with today's presentation? Uncontrolled and chronic refractory gout often reflect undermanagement, lack of access, and non-adherence, things that we can do something about. Gout flares are systemically inflammatory and can be associated quite strongly with subsequent cardiovascular events and mortality that are very significant considerations. Treating to urate target is disease modifying. It takes 1 to 2 years, but disease modifying in the vast majority of patients using currently available drugs, as long as protocols for the treatment are adhered to. And that's much easier in a clinical trial than the real world. Poor real world quality of care and outcomes, including the flare outcomes, the non-adherence, the need for too many dose titrations of allopurinol, allopurinol hypersensitivity syndrome, 25% mortality rate. Now appears that it's sensitive to JAK inhibition because of the interferon signature. This is a huge development. SGLT2 inhibitors, a very useful add-on in urate lowering therapy with specific comorbidities. And so you have to customize that to the comorbidity, but it'll reduce gout flares and reduce the development of gout and provide additional urate lowering. The pipeline of drugs includes oral URAT1 selective uricosurics that need minimal drug titration and are very highly effective as urate lowering therapy agents. And that the discovery that immune suppression substantially improves systemic uricase treatment success is a major advance. And the pipeline agent SEL-212 is immune modulator more than immunosuppressive. It delivers a durable serum urate reduction with monthly dosing, improves physical function, instrument measurements, SF36, HAQ-DI, and reduces joint inflammation and does that without infusion reactions being a problem. And then rheumatologists can lead the way in disease-modifying gout therapy with emphasis on better outcomes with the existing drugs and deployment of the emerging drugs. So I thank you for your participation, and you will receive an electronic initial evaluation to the email address provided. And here's instructions how to download the new ppcme.com mobile app for even greater access, including in your practice location, right by the bedside, basically, by logging in. Thank you for joining us for this 2025 Clinical Viewpoint Uncontrolled Gout lecture library series titled Precision in Practice, Elevating Care for Uncontrolled Gout. Please return to the activity landing page to claim your AMA, ABS, ANCC credit, access the downloadable slides, and access other activities.